And so I wanted to welcome you to the January 12th, 2023 meeting of the Monroe Community Coalition. We'll go around and do introductions. I think most of us know each other at this point, but still, let's do introduction for the minutes. And oops, looks like I'm needing to admit somebody. And let's start with Chris Gray. Chris, would you introduce yourself?
Hi, I'm Chris Gray. I am on the board of directors for Housing Hope, a nonprofit providing affordable housing for homeless and very low income families in Snohomish County. And my term has been extended because we are in the process of hiring a new CEO. And so I'm going to be there to go through the transition. So I was very honored by my board to say, we want to keep you on. So I'm going to be there for the rest of the year.
We're so glad you're here and that you're there. Mary Myers, how are you?
I am Mary Myers, a community member, 30-year employee of Monroe School District. My profession was a pediatric registered nurse and did a lot in the school district for prevention intervention programs before Joe came on board, and continued to build at an enormous clip on the work that I had done. I'm also the mom of 4 adults who all graduated from Monroe School District.
Thank you. Mr. Jury, I see you there.
How's it going?
Hanging in there.
Good. Yeah, so I'm Chris Jury. I'm the prevention manager for the Northwest ESD, and had a long track record working out in Monroe in a whole bunch of different contexts, most recently as an SAP at the middle school and high school.
Thank you. Brenna Smith, I see you. Thanks for hanging out with us.
Thanks for having me. Hi, everyone. I'm Brenna Smith. I am a healthy community specialist at Snohomish County Health Department now, formerly Health District. And I focus on opioids. So I am here for the opioid and Narcan training today.
Thank you. April Provost, nice to see you.
Good afternoon, everybody. My name is April Provost. I'm a community outreach coordinator with Ideal Option. It's a medically assisted treatment medical clinic that will be opening soon in Monroe, but we have multiple locations around the country. And I formerly lived out in the Sky Valley area for 20 plus years. So it is near and dear to my heart to be opening this clinic out here in Monroe.
Thank you. Chief Jolly, thanks so much for making the time to join us.
Hi, Joe. Hello, everybody. I'm Jeff Jolly. I'm the chief of police here in Monroe, and I'm just starting my 5th year and still learning plenty about the community, but loving every second of it. Last night, I don't know who was on Zoom or who was there, but if you happen to see Erin Jones and her presentation last night at the school district, what a phenomenal person. I don't say much about many speakers and how good they are, but she was one of the most fascinating people I've ever had the chance to listen to. So hopefully that sets off a good tone for the school and the school district going into this new year. And we see some good positive things coming with the new superintendent and the various things that are going on. And in our small teeny little way, I'm just proud and happy to be able to support the school district in their efforts and be part of this group.
Thank you. Chief, what was the conversation about last night on Zoom?
So it was in person as well as on Zoom, and Erin Jones, who resides in the Olympia area, came to talk about her new book, or her second book, Bridges to Heal Us. Wow. And it was a conversation about race, obviously, and some of the things that are going on. And we talked about things that impact us locally. But her message was just so refreshing and positive, and the manner in which we go about discussing these things was just contrary to the current environment that we see, where people have to be so divisive or have to call each other out on social media or whatever negative things that we can think of. And it was just more of a working together and learning together message. So it was just very positive. It just very timely. So it was good.
Thank you. Lisa Woodard, you keep coming back. I'm so glad to see you.
Yes, yay. So I'm Lisa Woodard, and I am one of the counselors up at the high school. Been in the district since 2004, been at the high school since 2007. So, and used to work with Mary Myers. So it's
Yeah,
super
it's
exciting
so
for me
good to see you.
to see her. Yay.
Thank you, Lisa. Great to see you.
Juliet D'Alessandro, welcome.
Thank you, Joe. I'm Juliet D'Alessandro. I am also with the Snohomish County Health Department on the same team as Brenna. And my work specifically focuses on coordinating our rural opioid response project and consortium. And I've been honored to be a part of this coalition for a while. So it's always nice to see all of you, and you especially, Joe.
Thank you. Amber Mehta, I think you were wearing my hat. Will you show us that hat again? Show us that hat again.
This hat is yours.
That's totally me.
Yes.
Totally. That's totally you. Would you introduce yourself?
Amber, I am the mom of a student at Frank Wagner who I had lunch with today, and she gave me the hat. So I also work at Park Place Middle School. I'm the student support advocate here at the school, and I have been part of the coalition for a while and part of the behavioral health team here at the school district.
Thank you. Pastor Michael Hanford.
I've been working with Mary and you, and before that, the East County Health and Safety Network for how many years, Mary? 20 some years.
Yeah,
And
Chris may have a better gauge of that history, but man, a really long time.
yeah, and of course, Chris Jury and so many of you. I'm a coordinator for Monroe Pastors Fellowship and Congregations, and I'm a police and fire chaplain. This is my 26th year, and involved in a bunch of stuff. So good to see everybody.
Thank you. And Aubrey, so glad to see you.
Hey, Joe, I'm Aubrey Rudd. I sit on the Just Serve Council for the area, and it's an app and a website, justserve.org. We're trying to connect people who want to serve in the community with opportunities. And I'm also the communications director for the Church of Jesus Christ of Latter-day Saints, Snohomish Stake, and I've got 3 kids in the district. Glad to be, I love being here. I've just loved the community connections. I've got a list of connections just from people I've met here. So thank you so much.
We're so glad to have you. And last but definitely not least, Mr. Jim Bloss. Thanks for joining us.
Thank you. Jim Bloss with NAMI, Snohomish County, National Alliance on Mental Illness. Have a 44-year-old adult son living with schizoaffective disorder, and we've been on our journey for about 25 years. So I know lots of people, and I just put some information into the chat box about our new family support group that's meets the 2nd and 4th Wednesday of every month. Open to anybody. You have to fill out an application, so we control the folks who come into the meeting and what have you, because it's confidential and all. But any if you need to contact me or need connections, just check in with Joe and he can find me.
Yeah, definitely. And Jim always knows where to find me. So it's a partnership there. So the newsletter contained the agenda and business updates. The business updates are pretty clear with regard to where we're at. Most coalition programs are full steam ahead. So if you're not sure where we're at, just for time's sake, I'll let you review it in the email I sent out and the reminder I sent out. And I'm happy to discuss it in person with you. For today, the agenda is pretty tight. We really have two speakers who we're going to learn from. Last month, we got to hear from Juliet. Juliet gave us a regional overview of opioids and emerging substances that may hit the landscape soon. That includes the spread of a substance called xylazine. Juliet gave us an amazing tour of the Snohomish County Health Department's opioid data dashboard and her work facilitating the Regional Opioid Consortium. This month, we're going to move from awareness of what's happening to awareness of what we can do about it. So I've invited two primary speakers here today. April Provost will speak first. She's going to tell us about Ideal Option, reopening facility here in Monroe that's focused on recovery through medication-assisted treatment. And when I was in a private conversation with April earlier last month, I realized that even in my role as your coordinator and being around the field for a long time, I had a lot of misconceptions about what medication-assisted treatment could look like. And so wanted April to be able to talk to us in her capacity as the community outreach specialist about her organization, medication-assisted treatment, and really allow you to interact with her about any questions that you may have. And when April's done, around 1:35 or 1:45 or so, we'll transition to Brenna, who's actually going to give us the same training that we give to law enforcement personnel, nurses, and others on the administration of Narcan, the opioid overdose reversal medication. And I know Brenna will be able to help expand on the teaser I left in the reminder or newsletter email about Narcan not just being for community members who may struggle with dependence on opioids, but really anybody who's been prescribed or is using an opioid. So I'm going to actually take a step back. And April, do you need me to give you screen control? Do you have slides?
I do have slides. I'm going to kind of go through them pretty quickly. So yeah, if you want to give me that control, I will pull up those slides.
I will do that, and I'm going to do that right now. So April, you're up, and I've made you a co-host. So
okay, so here we go. Okay. So I'm going to go through these slides a little more quickly because there's some that I want to concentrate more on than others. So again, we are Ideal Option. It is a medically assisted treatment center. So there are actually two different types of medically assisted treatment centers. We have what is called an OBOT, which is an outpatient treatment services provided by a licensed opioid treatment program. So there's OTP, which is the opioid treatment program, and that is your methadone clinics. So that is going to be where you're going to come in and you're going to do a daily dosing. It's got far more regulations on it because of the nature of the substance, which we will get into a little bit later. And it is not the clinical medical office environment that you traditionally would think of when you think of a doctor's office. So what we are is called an OBOT, and OBOT, which means that we are a medical clinic where you come in, you get a prescription, you are not dosed. It is like any other medical clinic. We do not dose on scene. You're given a prescription and then you go and pick up that prescription. So that's kind of the differences between the two programs. So there was some confusion around that before, and I wanted to kind of clarify that before we move forward with the slides. So we were founded by two ER doctors, actually, in Kennewick in the Tri-Cities area. And they kind of saw this revolving door of people that were coming in on overdoses and acute withdrawals. And there was no clinic that was out there prescribing Suboxone. So these two ER doctors started the clinics, and today we have over 80 clinics spread across the country. We're in 11 states, and it's been a very successful program. So we're going to kind of go through there. So one of the nice things about our clinics is that we have the ability, we don't have wait lists. We accept 3 of the 5 Medicaid treatments, and it's outpatient. It is trauma informed. We do not have judgment. So medically assisted treatment. Some of the benefits to this is it decreases illicit opiate use and other criminal activities. It decreases the transmission of an infectious disease. It decreases the rates of overdose and drug-related mortality. It increases the patient survival rate if they are engaged in treatment, and it actually gives them their life back, right? They're able to work on the things that they need to work on without the effects of the withdrawals, with a decreased amount of cravings. So the differences, kind of some of the differences here between the methadone and the Suboxone is methadone is what we call a full agonist. So it is a full reacting opioid in your brain. So it hits all the same receptors and gives you the same effects. It's kind of the flagship of medically assisted treatment. I think everybody was familiar with methadone treatment. Fast forward a couple decades and we have buprenorphine, and it is what is called a partial agonist. So it connects to the same receptors, but how it reacts in the brain and how the responses that it has are a little bit different. So what it's going to do is it's going to stamp out the cravings because the need for that receptor to be filled is being met. It is going to thereby create your withdrawal symptoms are going to be mediated. So you're not going to have those traditional withdrawal symptoms. But it is not going to activate in the sense of having the euphoric feeling, and it's not going to react in the way of having the respiratory depression. So most people, so infants and elderly excluded, for most people, you are not going to be able to overdose on Suboxone. The reason why is it has a plateau effect. So after 16 milligrams, it is no longer creating any response in the brain. Your receptors are full. It's not going to increase any feeling. It's not going to do anything more for you. So going and trying to get a higher dose of Suboxone or thinking that people are going to be trading it to get high off of it is kind of a misconception. That's just not how it works. We have a third medication that's used for treatment for opioid use disorder, and it's called naltrexone, and it's what we call an antagonist, and it's going to block the receptors in the brain. So there's 3 different ways that we can do this. We can fill the receptor the same way in replacement of. We can partially react in the brain and block all extra feeling from it. And then we have ones where we just block the receptor entirely. And so you're not going to get anything put into that receptor. Does that make sense? Everyone with me so far? Okay, perfect. So I need to put on my glasses, guys, because I'm getting a little up there. Really, the OBOT format and modality has emerged as like kind of the gold standard for MAT care now. With the onboarding of a prescription med, it makes it so that you're not having to come and dose on a daily basis. It's not as heavily regulated. People are able to go about their normal daily function in their normal daily lives without having that daily check-in. It's also readily available at most pharmacies. Your visit to the clinic is going to be less often, and we'll get into a little bit of what that looks like in here in a minute. But with an OBOT, again, you're going to have to be going in on a daily basis. It was kind of the original conception of MAT, and I think we're all pretty familiar with what that looks like. So I'm going to go ahead and skip to the good stuff. So how does Suboxone work? So it attaches to the same receptors, like I was saying, as other opioids, and only partially activates, and it eliminates the withdrawals and cravings, and it helps people to just feel normal. They've been activating those receptors for so long that it can be difficult for that response to go away and for people to have a feeling of normalcy for quite a long time. So everyone thinks, oh, it's just a few days of withdrawal and then you're fine, and that's just not the case. For the brain to reactivate and to rewire actually takes much longer. And if you have been using for say decades, these connections may never come back fully. And you may always struggle with that cravings and a lot of those feelings, and withdrawals can come in waves as it's dispensing through your body. And then the craving piece, as we all know, the mental capacity of addiction is far greater than even the physical. So buprenorphine can be used long-term, but it's going to be determined. It's an individualized plan that you come up with between your provider and the excuse me, and the patient, and it's going to be driven by multiple factors. There is not a cookie cutter, one size fits all for anybody's treatment program. I think that we can all are starting to learn that. So somebody who say maybe has been using for a couple of years, medium use, but on a daily basis, may need to go in the program and be able to taper off after a year, 18 months, 2 years. Whereas somebody who has been using this for literally decades, they may need to start it, they may be able to taper down in dosage, but the likelihood is that they're going to have to stay on it long term. And at this point, I think that we can all agree that if that's what it takes for them to be a normal, productive member of society and keeps them from returning to use, that is going to be absolutely 100% desirable over a return to use or death. So it's got to be determined by the provider what's going to work best for the individual, but that's just in a nutshell. So the other component in the traditional Suboxone is called the naloxone, and that's the antagonist, and it's going to be blocking medications if someone chooses to return to use while onboarded with Suboxone. So it can create some negative effect if somebody tries to use on top of it, but it's going to completely block their ability for the receptors to be at all impacted by the opiate. So Suboxone can cause precipitated withdrawal. So a lot of people, that's the number one concern, is that Suboxone didn't work to me because they had a negative experience with it. So say they started using it from something they did get on the street. They got a hold of somebody else's prescription, or they did not follow the protocols for induction onto the medication. What's going to happen is we call that precipitated withdrawal. So your receptors, if you can see on the slide, is the little cup, and then the green ball is the opioids, and that's how it attaches. It's just like a ball that attaches. The partial agonist is the little, I don't know, it looks like a jack from like the old game, where it has the little binders in it. So it's going to bind to a receptor more tightly and more effectively than any other opiate or opioid. So if you've used recently, say you use an opiate at 8 o'clock in the morning, and then you go and you try and take a Suboxone at noon, the opioids are still attached to your receptors. And when you take that on board, that Suboxone, it's going to go in there, and because it binds more tightly, it's going to kick all those opiates off and bind, and it's going to cause withdrawal symptoms because your brain is not going to know how to react to it just being all the opioids being dumped out. So it's much like a Narcan, has the same effect. So we want to avoid that, especially when we're dealing with fentanyl, because fentanyl has really changed the landscape of what drug use looks like for an opiate user. It was originally developed as to be part of an anesthesia, right? For hospitalizations, for extreme cases. It was never meant to be used as a traditional painkiller, let alone a recreational drug. So what happens is that it wears off fairly quickly, requiring someone to keep using more and more often. However, it stays attached to your receptors for much, much longer. And that's where we're seeing a lot of the problems, is that traditionally an opiate can be dissipated from the receptors within 24 hours of use. So back in the old days of heroin or regular Percocets or whatever they were using at the time, it was usually 24 hours before your receptors were free, and then you could onboard with a Suboxone treatment. Well, what we're finding with fentanyl is that, number one, it needs to be at least 36 hours before we can onboard you. And most people can't wait that long because the effects are wearing off, the the partial withdrawal is starting already, much, much quicker than it would with a traditional opiate, and people are just not able to get through that period. So we had to kind of rethink how we were going to address those individuals. We know that we can't lock them up and make them go through it. A lot of people are just not going to make it. If for anyone who has lived experience with an addiction like that, you know how horrible it really is. So we've come up with alternatives to the induction method. So instead of making people wait that 36 hours before starting on a normal dose, we have a low dose, which is the micro induction method. So what that does is it allows people to continue to use for 5 days while onboarding. So we're going to slowly introduce very, very small amounts of Suboxone into their system. So they're going to do maybe 1 milligram twice a day for the first day. Then they're going to double that and go up to 2 milligrams twice a day the second day. And then they're going to go up to 2 milligrams 3 times a day on the third day, and gradually introduce that as they continue to use, with the hope of by the 5th day, they've onboarded enough Suboxone that their receptors are being fully bound by the Suboxone, and they can transition and discontinue use and fully onboard with the Suboxone. We've found a lot of great success in this. It is a little controversial because we're allowing people to continue to use a substance, and most people are horrified at that, to be quite honest. Like, I mean, nobody wants to see their child, oh yeah, go ahead and continue to use for 5 more days. It's like, we want them to stop right now. However, we've found that if we try and make them press through that withdrawal period, they're less likely to be successful. So if they're being monitored, we are onboarding them with that Suboxone. We are requiring them to don't increase your use, but don't decrease your use. Use your status quo. Like, what is the least amount you can get by on? That's what you take. And then after that 5-day period, they should be able to transition nicely with very few severe withdrawal symptoms. The cravings should be manageable, and in conjunction with other treatment protocols, this can be a very successful method. I am in no way saying that medication is like your one pill wonder. Like, it does not work that way. It is a tool though. And for most people, it can be a very effective tool to get them transitioned to where they're having that clarity, that their brain is rebuilding, that their body is rebuilding, that they just feel normal. Now, a lot of folks, they don't know what to do with just feeling normal. They're used to the roller coaster. They're used to the extreme highs, and there's some disappointment and some things, mental things that go along with that feeling of not getting that euphoria. And so they give themselves up to think that that they feel crummier than they do. And what it really is that they need to start developing those tools to getting used to having just the status quo. They're not going to be on the roller coaster anymore. And that's oftentimes the hardest part of the addiction, is coming to terms with that. It's not about using to get high. It's about the euphoric feeling that it creates. And now they're having to kind of deal with all the ugly underlying stuff. And that's where we need to have, the counseling sessions. We need to have an SUDP. We need to give them those tools on how to navigate through that time period. But this is definitely helpful in curtailing those cravings, because if we just do the counseling, that can be effective too. Some people can do that cold turkey, absolutely 100%. But we've found that people tend to be far more successful if they're onboarded with this medication, whether it be short-term or long-term, to get them over the hump until they can develop the skills to go fully abstinent. So we have another dosing modality that we can use when it is not possible for people to continue use. So say they're in an inpatient detox. Say they don't have access to any more illicit substances, or they're staying somewhere where that is just not even going to be an option. We have the high dose, or the macro initiation method. And this is, it's going to be a little more painful, but it's going to be a lot shorter. So what we're going to do is we're going to make that patient wait as long as they possibly can after use. Typically, that can range anywhere from 12 to 16 hours. Some people less, some people more, obviously. And what we're going to do is we're going to onboard them with the highest dose, the maximum dose of 16 milligrams. And that more than likely is going to create some precipitated withdrawal. So they're not going to feel real good. We're going to have them wait a couple of hours. And then we're going to make sure that they are responding well, that they're not having any negative reactions to the actual medication, the actual buprenorphine or naloxone, that there's no adverse effects. And then we're going to hit them with another high dose, another 16 milligrams. And what that's going to allow for is that then those receptors are going to be refilled, and it's going to take away that withdrawal, and they're going to start to get some relief. So within 24 hours, generally speaking, they will be onboarded and be getting significant relief with manageable symptoms, and then they're fully onboarded with the dosing. So that's how that one works. Anyone have any questions so far? Okay, we're going to keep going. So what does it look like to start treatment with us? I know that there are other prescribers.
Sorry to interrupt. We do
Yeah.
have one question.
Sure.
For clarification, does the term provider in this discussion refer to a primary care doctor, a doctor from Ideal Option, or somebody else? Who do we mean when we say provider?
So when I'm speaking of providers, I'm speaking of our Ideal Option providers. I was just going to say there are other providers that are licensed to do to prescribe Suboxone. However, when you're going to a primary care physician, they are likely not as well versed on the different induction methods. They're not likely as well versed on addiction medicine as a whole. So this is when you're dealing with individuals of varying ages, of varying underlying complications. I feel like it's really important that we go to a specialist for this, that we go to somebody who is on the cutting edge, that is fully developed, that is continually developing in this specialized area. Addiction medicine can be tricky. It is not a one size fits all. It is not a, oh yeah, just wait 24 hours, take your Suboxone and you're good. I absolutely think it would be appropriate to transition it to your primary care physician once you're stabilized and you're on a dose where you're going to be comfortable with staying at. Then sure, then we can start thinking about, transitioning that to a primary care physician. But at least for the first, I'm going to say year, it would be important to stick with somebody that is specialized in it, because you may decide at the end of that year that I want to start to taper down, or I might want to start to taper off. And doing that effectively is going to be really important, because there is going to be a physical addiction to the Suboxone, but it will be a manageable taper that you can taper off of and transition off of nicely. I've seen hundreds and hundreds of cases of people being able to successfully transition off of it. But it is not something that you're going to want to stop cold turkey. It just isn't.
April, does the team at Ideal Option work with a patient's primary care physician?
When medically necessary, they do.
Got it.
So that would typically happen if there were underlying health issues. So they're definitely going to keep in contact. They're definitely going to be able to work together. Absolutely. But we don't prescribe anything outside of the genre of addiction medication. We do offer comfort meds, which are not technically medically assisted treatment, but they will help you get through some of the discomfort. So you might experience, I don't know how many of you are familiar with some of the withdrawal symptoms, but typical medications would be something to help you with your nausea, because that is a common problem. Any kind of stomach upset, disruption in bowel movement, a mild like a hydroxyzine and a clonidine to manage anxiety and restlessness. And in some cases, a very mild sleeping pill that will help with get you back onto a normal sleep schedule. But those are going to be very short term. Those are not going to be something that you're going to be prescribed indefinitely. It's like, we're talking like 7 to 10 days maximum for comfort meds. So when somebody starts treatment with us, how we differ from maybe going to a primary care physician where you're going to go in and you're going to see them once a month. That modality doesn't usually generate enough accountability and enough scope to make sure that somebody is truly stabilized. So we're going to see you at your first visit. It's going to be a longer visit, going to be about an hour. We're going to get you onboarded. We're going to give you access to an ideal balanced counselor that is going to ask you if you want an assessment, ask you if you want help getting into inpatient or detox, outpatient services, what kind of barriers you face, how can they help you with local resources. They are also available to do level 1 outpatient services, which is up to three half-hour sessions a week. So it is not in place of an intensive outpatient. It is not group sessions. It is strictly one-on-one, and it's to help to do those warm handoffs to other agencies that are going to be giving you the true addiction counseling that you're going to need. So we're going to see you twice a week to get you onboarded. Then we're going to put you on to once a week. Once you are at a stabilized dose, you're going to be asked to perform a UA at every time you come in. The second visit, we're going to do your labs. So we're going to do your STI testing. We're going to do your liver enzyme testing to make sure that you have good liver function. We do offer Hep C treatment through our clinics as well, because I know that that is a huge component. We're going to do referrals for you for any of the other STIs. We're going to make sure that there's just no underlying other health complications in your blood work that may deter you from being able to take these medications.
Sorry, I accidentally muted you, April. We have about 3 more minutes.
Okay. Anyways, we're going to get you onto a stabilized. We're going to keep, every time you get 3 clean UAs, we will bump you out another week until you are ultimately at a once a week. On top of that, we do offer injectables. So there is an injectable version of the Suboxone. It's a once a month injection. Hit me up if you would like to learn anything more about that. The other important component that I think that you guys have me here to share is that we do treat youth. We will accept youth. Our youth protocols are going to differ a little from our adult protocols. One of the important aspects that Joe had mentioned in my conversation with him earlier is that we do not want to over medicate people. We want to give the least amount of medications to an individual as possible, and in particular with youth. So if we have a youth come in that's been using for a few months and they've been using fentanyl for a few months, it may be deemed medically appropriate to help them just get through the detox period instead of onboarding them on Suboxone. So we're going to differ in our protocols and follow, FDA regulations on the medications, but we are going to be able to see our youth. And we have a great provider that's going to be there in the Monroe Clinic, Brittany Harris. She's wonderful. She's a little younger as well and is really looking forward to any of the younger programs that you might have for us.
April, where's the clinic located?
So we are going to be on the top floor of the 101 Main Street building. So it's the 2nd floor. Our clinic will be tucked in there. Again, it's just like any other medical clinic. You're going to make your appointment. You're going to sit in the waiting room. You're going to go back. You're going to see the provider, provide your UA, and then you're going to leave and your script is going to be sent to the pharmacy of your choosing.
And when do you start accepting patients?
So we are looking at a soft target dates to open in mid-March. So I will let you know when we have a firm date, but right now we're in the build out phase. We had to do some slight modifications to the space to get it ready, but we're looking to open in March.
Thank you. Thank you. And I'm so grateful that you're able to join us and you've been coming to more and more meetings, and it's just wonderful having you here. I'm going to hold off questions until the end so that we can give Brenna a chance to show us how we can save lives. But just knowing that you're here with us gives me confidence that we're going to be able to make this a dialogue instead of a presentation.
Absolutely.
And so grateful for you. Brenna, I'm going to make you the co-host right now, so you can share your screen.
Great.
Oop, I almost did that. There we are. And then if you have any questions for April as we're moving forward, why don't you put them in the chat box? And if she can't answer through chat, then I'll collect a list for her to answer offline for us. Okay, Brenna, it's all yours.
Great. Okay. Everything ready. All right. So now we're going to go over our opioid and Narcan training. So we're going to start off just with some general information just to make sure everyone is all on the same page. We'll go through that quickly though, just because it seems like this group does have a little bit higher of knowledge. And then we'll talk about who's affected by overdose, how to recognize an overdose, and then how to use Narcan. We're also going to cover some brief strategies at the end for preventing misuse of opioids. And feel free to put in questions in the chat, unmute. Want this to be pretty engaging. So why is this training important? I mean, I think you all understand that, but if you know someone who uses opioids, this training will help you be prepared to save their life. And if you don't know anyone who uses opioids, this can just help you gain an understanding of how they impact our communities and what we can do to help prevent them. We're going to skip that for the sake of time. So how do opioids work? They, of course, reduce pain. As April was talking about, they do give feelings of happiness and euphoria. And they can also reduce someone's ability to breathe at high doses, and that is what's going to result in an overdose. We want to have a little bit basic understanding of tolerance. So this is opioids are a tolerance-forming drug. This means that after taking opioids for a period of time, a person will no longer respond to the drug the way they did initially. So they'll need to take more doses to get that similar feeling. Same thing with other substances like alcohol. Tolerance building, you need to drink more over time to get the same effect. Dependence is when the body's used to having that substance. You do not have to be addicted to become dependent. So this is when you're no longer, when you stop taking opioids and your body's dependent on them, that's when you're going to slip into those withdrawal symptoms. And then addiction is defined as a compulsive drug use despite harmful consequences, such as failing to meet work, social, or family obligations. With opioids, it's opioid use disorder. And it's a disease where someone's brain chemistry has changed, so they have these uncontrollable cravings and an inability to stop opioid use. So with this condition, we want to keep in mind that someone's willpower, however strong, is not going to make much of an impact. That's why we need all the wonderful things that April was talking about with MAT and medication-assisted treatment and all those other great things. And then we also just want to cover harm reduction, just in case anyone is unfamiliar with this term, but it's an evidence-based approach and it's part of the continuum of care for people who have substance use disorder. It's going to help reduce the negative consequences associated with drug use, such as overdose and death. So we can continue to help save lives so people can continue on with their recovery journey. Okay, really quickly, what kind of opioids? We've got our prescription opioids, oxycodone, hydrocodone, morphine. There is the pharmaceutical fentanyl. Like April was talking about again, it's a medical setting, and pharmaceutical fentanyl is not where we're concerned for overdose. C, of course, covered our medications for addiction treatment, so I will not talk about those. But then we have our illegal substances, which is the heroin, and then the illicitly manufactured fentanyl, and that's the fentanyl that we talk about when thinking about overdoses. So how do people take them? You can swallow them. The pills can be crushed up and snorted or smoked. You can inject opioids, of course, but we are seeing a decline in injection use and an increase in smoking when it comes to using opioids. And then in a medical setting, the fentanyl can be given through IV. But again, there's medical staff nearby, so overdose is really not a concern there. Okay. So now we are going to talk about some situations that can create risk for overdose for people who are using opioids. So one example is going to be a person who is introduced to prescription opioids after an accident. So although they receive prescription to manage their pain, if they take opioids for an extended period of time, their tolerance is going to grow. And so what used to stop the pain might not anymore. So they might take additional doses to help with that pain. And it is when we get into those additional doses that we have a concern for overdose. Another example are people like teenagers, youth who find opioids in their medicine cabinets at home or at a friend's house. And they take them because they're curious how they will feel, or maybe they already know. And then children can also be at risk if they get into medicine cabinets because pills can look like candy. Another group are people who are forgetful or have memory loss. So an elderly person with mild dementia could forget that they've already taken their opioid medication for the day to manage their chronic back pain. So they take extra pills. Again, it is those extra pills that causes the concern for overdose. So another group are people who have not used opioids for a few days or more and then start using again at the rate that they were using prior to stopping. So they could stop for treatment. Maybe they had spent some time in jail, or maybe they attempted to stop using on their own, but regardless, if they again start using at the level they did before, that can create risk for overdose because their tolerance has dropped. And then, of course, people who use opioids that contain fentanyl are going to be at a higher risk of overdose. We understand that fentanyl is a much more concentrated opioid. This picture shows a lethal dose of heroin versus a lethal dose of fentanyl. So we can see how much more deadly fentanyl is. And as April was discussing, fentanyl goes through your system a lot faster than other opioids, which can cause people to take doses more frequently to sustain that high, which is going to further increase risk for overdose. But it is saturating the drug market because of how cheap it is to make and buy, which is really unfortunate. So fentanyl can be found in pills that look identical to prescription opioids like Oxycontin or M30s, which is that first picture of the blue pills. If anyone buys these on the street, it is most likely going to be fentanyl and not the medication it is being advertised as. Fentanyl can be found mixed in with heroin samples as well, which is that second picture. And then fentanyl can also be found in other non-opioid substances, such as stimulants like cocaine or meth. This third picture is of meth that has been mixed with fentanyl, and that combination has been on the rise in recent overdose trends. I also want to highlight that our emergency departments are now seeing an increase in overdoses caused by fentanyl among people who believe they're using cocaine. So it's being found in illicit white powders now. And then people who use multiple substances at the same time, which is also known as polysubstance use, they're going to be at greater risk of overdose. Some people choose to take multiple substances at the same time, like opioids and benzodiazepines like Xanax, or opioids and stimulants. But not everyone chooses that. They might not be aware that what they're taking has been mixed with other substances, but when combined, it's always more dangerous. I'm going to quickly go through some data points here. So this is an image of a graph for all drug poisonings in Washington state through 2021. So in 2021, we're looking at this red line. Opioids were responsible for 37% of all drug poisonings. And then in this image of the same graph, we're just looking at that orange line now. This is the combination of opioids and methamphetamine, and they're responsible for almost 28% of all drug poisonings in 2021. And finally, here we're looking at the blue line on the same graph. It's overdoses caused by methamphetamine only, and it is responsible for almost 23% of all the drug poisonings. So we just wanted to show you that just to highlight how prevalent methamphetamine, as well as the combination of methamphetamine and opioids, are at the moment. And so for that reason, I'm going to talk about methamphetamine for just a couple of minutes. So the reason why people may choose to be using both meth and opioids is because meth is also very easy to find in Washington right now, and it's also very cheap. Some people may enjoy the combined effects, but however, for some people who may be living on the street or do not have stable living environments, if they're using opioids, they may also use methamphetamine to help them stay awake for survival purposes. And so really quickly, here are some meth overdose signs and symptoms in case you encounter that as well. With methamphetamine overdose, that often leads to a stroke, heart attack, or organ problems. There can also be behavioral health symptoms like extreme paranoia and agitation. And to treat a meth overdose, first responders and ER doctors are going to treat the heart attack, stroke, or organ problem symptoms. And to treat methamphetamine use disorder, behavioral therapies are going to be the most effective for that. And if you have questions, I'm sure April might have more information on that than me. Maybe I'm wrong. But getting back into opioids now, here are opioid signs and symptoms for a high in an overdose. So when we're looking for an opioid overdose, what we want to look for is if the person has pale or clammy skin, if they are not breathing or very shallow breathing, they may have some deep snoring or gurgling noises. They'll be unresponsive to someone calling their name, shaking, a breastbone rub. They may have a slowed heartbeat or pulse. And for people who have whiter skin complexions, they will have blue around their fingertips and lips. And for people who have darker skin complexions, it's going to look kind of ashy around the fingertips and lips. And then they will also have small pupils. If someone's high on opioids, we want to keep an eye on them because it could escalate into an overdose. So we never want to leave them alone, and we encourage that people never use alone for that purpose as well. Okay, so how do opioids impact breathing? This is an image of the brain and the receptors inside. So in our images, the receptors look kind of like these little corkscrews. But when opioids go into the body, again, as April touched on, they connect to those receptors in the brain. And if enough receptors connect, someone's breathing can slow and then stop. And that is what causes an overdose. And it's just important to keep in mind that if someone isn't breathing oxygen within 3 to 5 minutes, brain damage can start to occur. So a timely response is really important. Any questions before we get into Narcan? The chat. Okay.
Great job, Brenna.
Thanks, April. All right, so what is Narcan and how does it work? So we want to give this medication right away to reverse a possible overdose. It is going to start working within 1 to 3 minutes, and it lasts for 20 to 90 minutes. Waiting the 1 to 3 minutes doesn't sound like a lot, but it can feel like a really long time in that moment. So it can be helpful to watch the time or set a timer if that is all possible for you to do in that moment. We also want to note that the medication in the cartridge is called naloxone, but the brand name is called Narcan. So you may hear those terms being used interchangeably, and that is why. So what Narcan does, and again, April was touching on this, but it knocks those opioids off those receptors and takes its place. This is going to temporarily remove the high, and it gives a person a chance to breathe. This is Narcan's only function. So if someone does not have opioids in their system, Narcan will not have any effect. It also will not harm the person. So we always encourage people to use Narcan if they have any suspicion that someone is overdosing on opioids. And if there are other substances in the body like methamphetamine, it's only going to work on the opioids, but again, it's not going to have any harmful reactions to the other substances. So some additional information, a box is going to contain 2 doses. They expire after 3 years, and Narcan is best kept at room temperature. So below 55 degrees and above 80 degrees can cause the medication to lose its effectiveness. Limited and accidental exposure is going to be okay. We just don't want to leave Narcan in our cars overnight regularly. And then other things to keep in mind, it cannot be abused or cause an overdose. It has a long history of safety, and negative side effects are very rare. If the person, again, has not overdosed, there's no effect on the body. And using Narcan on someone does not increase later drug use. Studies have found that increased access to Narcan has showed no increase in opioid overdoses or opioid misuse, which is great. And then it is also recommended that people who are pregnant still receive Narcan as well if they are overdosing, because it could save their life as well as the baby's life. There can just be a risk of acute withdrawal. So we just want to make sure that they are seen by medical professionals right away. Okay, so that is all the information on Narcan. Next, we're going to get into the response. But are there any questions generally on Narcan? Okay, so we're going to get into take action, the 4 R's. So first, we want to recognize if the person is showing signs of an overdose. Again, unresponsive, little or no breathing, gurgling, slow or no heartbeat, pale or clammy skin, and blue or ashy fingertips and lips, and those small pupils. We want to get a report from others who saw what happened. We want to understand if there is a history of opioid use or overdose. And we want to see if there are any nearby medications, illegal drugs or drug use supplies, or anything that is going to tell us what happened there and help paint that scene for us. If you notice any of these things, we want to ask the person if they are okay really loudly. We want to kind of shake their shoulders, and you can do a breastbone rub or sternum with your knuckles. So you want to take the knuckles on your hand and you can rub that on their sternum. The reason that we suggest this is because it's a really painful physical stimuli that's not going to cause harm to them, but if they don't respond to that, it is a good sign that they are overdosing and it is time to respond. We want to call 911 for help. If you are alone, you can put your phone on speakerphone, but if you're with someone, I recommend delegating the task of calling 911. You can say the person is not breathing and unresponsive to make your call a priority, and give really clear details of your location so you're easy to find. there is the Good Samaritan law, and this protects both the person who overdosed and the caller from drug possession charges or prosecution, which includes the use of substances, but it's not going to protect against any other crimes. So just important to keep in mind there as well. While calling 911, if you are the person, if you have to do it on speakerphone or if you delegated, at kind of around the same time, you also want to administer that first dose of Narcan. And then when the paramedics arrive, you can tell them as much as possible about the drugs that the person might have used, so the paramedics can give them the best medical care. Really anything you can do during this time to help save someone's life is going to have a big impact. We're gonna watch I think it's about 2 minutes from this. It just does a really good job of showing what this response might look like.
Unresponsive and you suspect an overdose,
Can you all hear
first
that?
shake their shoulders and shout their name.
Kevin.
Ask if he or she is okay.
Hey, can you hear me?
Check for signs of an overdose. Unresponsive to touch or voice. Breathing is slow, uneven, or has stopped. Snoring, gasping, or gurgling sounds. Fingernails or lips are blue or purple. Administer Narcan nasal spray as quickly as possible if someone is unresponsive and an opioid overdose is suspected, even when in doubt, because prolonged respiratory depression may result in damage to the central nervous system or even death. Lay the person on their back to receive a dose of Narcan nasal spray. Remove Narcan nasal spray from the box. Peel back the tab with the circle to open it. Remove and review the printed quick start guide inside the package. Hold the Narcan nasal spray with your thumb on the bottom of the plunger and your first and middle fingers on either side of the nozzle. Do not press the plunger to test or prime the device. If you do, you will waste all or part of the dose of medication. Tilt the person's head back and provide support under the neck with your hand. Gently insert the tip of the nozzle into one nostril until your fingers on either side of the nozzle are against the person's nose. Press the plunger firmly to give the full dose of Narcan nasal spray. Remove the device from the nostril after giving the dose. After you have given this medication,
Okay. All right. So if you are trained, you can also give CPR if you determine that that is needed. If there is no response within the 3 minutes after giving that first dose of Narcan, you can give the second dose in the opposite nostril, and you can continue CPR if you're trained to do so until they start breathing on their own or until help arrives. If the person does start breathing on their own but does not wake up, we can roll them into the recovery position, which is the image on the screen here. So they will be on their side with one arm bent up and out and the other under their head, and the top leg will be bent. So this position is going to keep them on their side, and it's going to prevent them from choking if they vomit. As a reminder, we never want to leave them alone, but if you do have to leave someone alone, say to let paramedics into the building, this is the best position to leave them in. And then if you need more than 2 doses of Narcan, which is sometimes possible with fentanyl, you want to continue waiting those 3 minutes in between doses and alternating nostrils. Some people have seen as high as 7 doses of Narcan being needed to revive someone. So it can get up there. With the reverse, as April was mentioning, there's going to be withdrawal symptoms. So these are some common withdrawal symptoms on the screen, and they can be fairly strong. So we want to keep in mind that the person might not remember that they overdosed, and so they might be scared, nervous, restless, or agitated when they wake up. So we want to try and give them some space if you can, and then try and keep them calm until help arrives. We also want to try and stop them from taking additional drugs at this time. it is likely that they are trying to reduce those withdrawal symptoms and not to get high again. So doing your best to stop that. And then we want to make sure that that person is taken to the nearest medical center, even if symptoms do seem to be getting better. This is important for a few reasons. So the first is that if the opioid dose was too strong, the Narcan you gave them might wear off and they can slip back into an overdose and stop breathing again. Remember, Narcan lasts 20 to 90 minutes. The medical professionals will have additional Narcan to help with that. And then the person will be in withdrawal after getting Narcan. And so at a medical clinic, they can help manage those symptoms. And then a hospital can also assess if there are any other medical needs that need support, such as injuries or mental health challenges. You can follow up with the person after the incident once they're doing okay. And you can talk to them about seeking treatment if they have not been referred already. There is a number on the screen for the Washington Recovery Helpline. I have this saved in my phone under favorites in case I ever need it. They have interpretation services in over 200 languages. And you can call them for substance use challenges, mental health challenges, or problem gambling. And then we also want to emphasize that self-care is really important when supporting someone who has overdosed, because this experience can be stressful and it can bring up some hard emotions. So we encourage everyone to find someone to talk about their experience with, whether it's a friend, family member, or mental health professional. But while doing so, keep in mind that we also want to protect the privacy of the individual who overdosed, so not sharing any identifiable information about them. Any questions before we get into next steps? Okay. How and where do I get Narcan? So Washington State has a statewide standing order. This acts as a universal prescription. So there is no personal prescription required to get Narcan. To carry Narcan, it is covered by most insurance plans. Without insurance, the cost can range from $125 to $160, so it's pretty expensive. Private insurance will likely have copays as well, and those can vary. So I would contact your insurance to find out what those copays might look like to see if that would be an affordable option for you. Medicare does cover it for free and unlimited. And there is also this wonderful resource with the People's Harm Reduction Alliance. They are mailing people free Narcan around Washington. It's discreet shipping too. So you can go to their website and fill out the form. It can just take some time to receive that Narcan, and you do not get a tracking number with it. I ordered my Narcan through them and it took about a month to arrive. So keep that in mind as well. And then here at Snohomish County Health Department, we're also working to partner with organizations like Ideal Option with April to make Narcan accessible through outreach. We also work with a lot of local police departments. So what more can you do to prevent opioid overdose? We can talk to our friends and family about medication storage. We know that opioid misuse can start with people using medications not prescribed to them. So it's important to keep medications up high and out of reach with a child-proof lock. We want to keep in mind that those child-resistant containers are not child-proof. And so investing in a medication lockbox or a lock bottle is the best option. There are some cheap ones that you can find on Amazon. And then you can also get rid of old, expired, or unused medications. We do not recommend flushing them down the toilet or throwing them away. If you flush them down the toilet, they can get in our water systems and they do not get filtered out, so it can affect our plant and wildlife. And throwing them away, they're still accessible in the garbage. So we recommend bringing them to a local pharmacy. Some police stations will also have some drop boxes. And then you can also call the Med Project at this phone number. They can send you a mailback package to your home for free. And you can take back a variety of medications, not just opioids. But that's it. You're all trained to administer Narcan now. Any questions?
I have a question for you, Brenna.
Yeah.
So I've run into this in the field in administration of Narcan, where if somebody has a clogged nose, so lots of mucus coming out of their nostrils, you're not sure that it's really going to penetrate. Is that going to have an effect on the naloxone medication?
That's a good question. I don't think so. I do not think so, because it is it like seeks in through your mucous membranes. So as long as you can get it in the nose, it should be fine. Any other questions?
For those who administer naloxone, is there a risk of violence as a person may suddenly recover from their overdose with IC nods? How do we keep safe?
That's a great question. Yeah. So yeah, like I said in my training, they might not remember. So if you're just like hovering over them, that could freak them out, right? Like I would be freaked out if I woke up and someone was hovering over me. So yeah, step back, try and de-escalate if you can, but safety is of course super important. So keep yourself safe. Call 911 if you need to. Anything else, April?
So I often find people will overdose while slumped in a chair, and there may not be space or whatever to actually get them into a laying down position. So a lot of times when they're slumped, they're like this. We want to make sure that we just tip their head back, palm here, like this, and make sure that you have that clear airway, so that when you administer, and then you want to keep that airway clear. You don't want to let their head slump back down, because if they are slowly regaining the ability to breathe. So I know that kind of goes against the Narcan and step back for safety purposes, but if you can just stand off to the side, they're not likely to wake up and immediately turn to swing or harm you in any way. But just making sure that we keep that breathing open, that airway open, is going to be really important. I've seen it done incorrectly where they've let it slump back down, and we want to make sure that we don't do that.
I see Chip Gloss has raised his hand.
I left a message for Brenna in the chat, but I'll read it.
I was just reading that. Thank you, Jim.
Yeah, that's okay. As I should say, are there any stats, even guesses, as to how many overdose situations end up not being reported? I have a relative, actually works for the CDC, who works on the data collection side of reporting, who indicates it's very difficult to maintain accurate data as to occurrences, given many people not wanting to report that they're using or having used. So I don't know that there's an answer to that, but I would think maybe a broad guess, a certain percentage of folks that just that the data just isn't being recorded or reported. I mean, because of that.
Yeah, that is an excellent question. I do not have a guess off the top of my head. We do have an epidemiologist on our team that I can follow up with and get that kind of ballpark number and follow up with you if you would like.
I asked.
You have our. Oh, go ahead.
Go ahead. I said have it. I asked a good question because my daughter's an epidemiologist.
Okay, yeah, then you understand.
Oh yeah.
So we do have our data dashboard that it sounds like Juliet showed you all last month. And that data, I mean, it's the people who are going to our emergency department. So that's a very specific population. We also get data from medical examiner's office, but of course that only captures fatalities. With our law enforcement partners, I work a lot with first responders, and we provide Narcan for them, and they report the use of that, and they send that data to us. So we have a few ways to get an idea of the data, but it's not perfect. And like I said, it's very specific portions of the population. It's not wholly representative, I would say. But I'll re-put the link to the data dashboard in the chat for you all. And
Thank you.
I can follow up with you, Jim, once I get a better ballpark number.
That'd
I
be great.
think that number is going to be fairly significant because most people are not going to report if they are individuals that are all using together in an environment. I do leave behind in high drug areas with members that are using, and they 9 times out of 10, unless they are unable to fully resuscitate, they generally speaking are not going to call 911, and it is not going to be reported.
It's suspicions confirmed.
So Brenna, my hope is as you learn about ways that we can get the actual reversal medication into folks' hands, you'd share that with us. If somebody does obtain Narcan on their own, how long can they keep a dose for before it expires? What's the expiration date?
About 3 years.
About 3 years.
And that will be found, I have a box next to me. So that will be, let me turn the blur off my video so you can actually see what I'm trying to show you. It's going to be at the top of the box here. And then it's also going to be on each individual dose of Narcan as well as those reminders. But with the expiration date as well, if it's past that, it just, it's less effective. It's not bad per se. So if you have expired Narcan, I recommend still hanging on to it until you get replacement doses, because some is better than none.
That makes sense.
Yeah.
Any other questions for our two amazing guests today, Brenna from the Health Department and April from Ideal Option? Well, okay, I see applause and thank yous, and we really appreciate you sharing your expertise and time with us, and hope to see you again. Thank you so much.
You are welcome.
So
I
much
will be out in the community to do outreach in your community on a fairly consistent basis, and we are hoping to do in-clinic Narcan trainings for the community members as well. So I will keep you posted when I get more information.
Wonderful, wonderful. And if any coalition member would like April or Brenna to come out to their organization, are you available to do that? So if you have interested constituents who want to learn more about Ideal Option or Narcan, email me and I'll connect you with them.
I also put my email in the chat for you all.
Or email Brenna directly. Take me out as the middleman. What a mercy. Oh, Mary Myers, I see you.
So this is probably more a question posed to you. Have there been ongoing conversations within the school district of employees in select positions having Narcan and having approval to use it?
It's the
or
law.
is the pardon?
It's the
is
law.
the expectation that 911 be called and the school personnel be removed from any active role?
Yeah, so all school nurses have been trained to administer naloxone and have access to the nasal spray. So after administering the nasal spray, we would call 911 and get them some medical assistance. But yep, so 5 years ago when we were trying to push it through, or 6 years ago and trying to help the district understand the need and we're encountering resistance. Today it's the law, so all school districts have naloxone.
Didn't know that. Thanks, Joe. That's great.
I can add on that as well and say that Juliet and I's coworker Abby does a lot of work with schools in the county as well, and she's making sure that all schools do have Narcan on hand and that it's in an accessible place.
Good.
Well, with that, I think I can give everybody 5 minutes back. I'm going to stop this recording and say see you in February. You can hang out if you want. Otherwise, thank you guys.
Thank you.